Okay. I think we're ready. So today is the day before Thanksgiving, and we have some info to finish up about contraception. And then I may also include a little bit about pregnancy, but I think a lot of students will be watching this online. So when we had stopped last time, we had gotten to the part of contraception that we had been in the middle of hormonal methods. And remember that all of the hormonal methods are going to keep female hormones fairly steady for at least 3 weeks so that they block ovulation. And one of the other ways that hormones can be delivered is through intrauterine device or IUD. And there are two different kinds of IUDs. One of them includes hormones and it acts like the other hormonal methods. The other one does not. Whoops. Go back there. So I'm going to talk about both of the two styles, and there are things that they have in common and things that are different about them. So you can see here in the picture of this person's hand, they are holding an IUD, and this is one of the hormonal versions. And it's about this size, and you can see it's kind of T-shaped. And there are some very small strings right there. And then you can see another version up here, which is the non-hormonal. It's also T-shaped, and it's got some strings. So the way that intrauterine devices work is that they're inserted into the uterus. So the bar is in the uterus, and the vertical part goes through the cervix. And then the strings are there for removal at some point. So bar in the uterus, vertical part through the cervix, and then strings would be just kind of subtly in the vagina. Probably the greatest benefit of IUDs is that they are very long lasting contraception, but they're also reversible. So there are some versions that can be inserted and will be effective for 5 years. There's some that are 10 years. So the long actingness is a huge benefit. The drawbacks of them are this is not something that you can put in yourself. You have to have a doctor's appointment. Doesn't have to be a doctor per se, but a medical professional will put in IUD, and it can be a little bit painful to get them in. But once they're there, and they're very long acting. So the two different types are the hormonal type, like Mirena, that's one of the brand names. And then a type that's non-hormonal, which is like this, and one version of that is Paragard. So both of these, it's really difficult to use them improperly. So both of these would have a low failure rate. And the ways that they act are a little bit different. So if you're watching this on Teams, I just wrote the word low in each one of these blanks right here, just the word low and low for the failure rate. So for the methods of action, the method of action of the hormonal type is going to be the same as any other hormonal type. So it will prevent ovulation. For the hormonal type. And it's using slow release hormones that get released over 5 years. The other type tends to be made out of copper. So when you see on this picture that the one up here has the vertical component looking a little bit orangey. That's copper metal. And the copper metal acts in a little bit different way. So it's going to inhibit sperm action. And it is going to change, let's say it's going to change the properties of cervical mucus. So it's not using hormones. And if women need to use a long-acting, non-hormonal method, this would be a good choice. It's also important to note that these can be removed at any time. So if it's a 5-year time frame, you don't have to wait 5 years. You could have it removed at any time in a medical appointment. IUDs have become way more used and way more popular in the past 20 years. And they do have some particular risks to them. So if you're watching this online, I would like you to write down a risk. One of the risks of these is that they can migrate out of place. So sometimes it's a low chance of this, but sometimes they don't stay where they're supposed to be staying and they'll migrate to a different spot, or also a very small risk of uterine perforation. Like get stuck in the wall of the uterus or poke through it, and that can cause some bad complications, but that's super rare. I feel like these are going to become more popular as some states are putting more controls on what kind of birth control you can get and what kind of female health care you can get. So it's good to know how these act and to know that these are an option. And I think most insurance would pay for these. Also important to note before we go on to the surgical methods, IUDs do have to be inserted by a medical professional, but they are not considered a surgery. This is not an invasive thing, and it's doesn't take long. It's a pretty short office visit. It's not really surgical, and this IUD method is easily reversible. And I want to also reflect back to your guys's chart. So we have that chart of methods, and I want to show you where IUDs fall on that chart. There it is. Okay, so on our table of methods, Mirena is a IUD, and that one is hormonal. So this is hormonal version of IUD, and you can see it has an incredibly low failure rate, and you can't use it quite wrongly. So the failure rate's the same with typical and perfect use. And then the next one down, this TCU or Paragard or Copper T, that's the non-hormonal. And that one also has a low failure rate. It's not quite as effective, but still very low failure rate. That one is not hormonal. That's more of a barrier type method. So if I were making this chart, I would put this version of IUD into a category with barrier like condom. And then these other things that we talked about last time, these are hormonal. Marina is hormonal. And they kind of go together. So what we're going to talk about next are these two, which are both surgical. And I think this chart is a little bit weird that it puts male sterilization under intrauterine device. It's not. It's totally not. But that's what we're going to look at next. So let's go back to those slides. So there are surgical contraception methods for both male and female. And we'll start with the male one. So the male surgical method is called vasectomy. VASECTOMY, vasectomy. And a vasectomy is acting on vas deferens, so the name makes sense. And to perform a vasectomy, a medical professional will make a small incision through the scrotum and find the two vas deferens coming from each testis. Cut them, it's a little snip, and then kind of tie them off so that sperm from the scrotum cannot go past the testis, basically, or can't go past this part of the vas deferens where it was cut and tied. If you're taking notes on this, please write down that this is an outpatient procedure. This is a relatively minor procedure from a physical sense. It might have some, a bigger deal psychologically, like you don't want to just decide this on a whim, but the actual medical procedure is not that invasive and it's not very risky. Lately, the past few years, people have had more of an idea that this is reversible. It's technically reversible, but no one should be choosing these surgical methods thinking that they're later going to easily reverse them. So if you think about what would have to happen to reverse this, it's a microsurgery to slightly stretch the remaining parts of the vas deferens and sew them back together and hope that there's no scar tissue blockage. So that can be done, but I would not encourage people to do this and then think, oh, I'll eventually get that reversed. It's not that easy to get reversed. So the way that this is acting is that sperm will not leave the testis, and so sperm cannot go and fertilize an egg. Two important things about vasectomies. Firstly, it's very important in a vasectomy to observe what's called the washout period and still abstain from sex for a few days after the vasectomy is finished. Whoops. Okay. Because right after a vasectomy, there still can be some sperm up in these distal part of the ductus deferens. There still could be some sperm up here. So men are supposed to wait a few days after a vasectomy before they have sex if they had a vasectomy for contraception, which why else would you? If you don't wait a few days, there is a small risk of pregnancy, and that's happened to guys, and it would be, just so disappointing. Like, why go through that and then not wait a few days? It's very important to wait a few days. So if you look back at, again, our table, and you see here that male sterilization has a very low failure rate with perfect use, and it still has a low failure rate with typical use, but it's not the same number. That little difference is basically from guys who didn't wait enough days. And that also tells you how non-invasive that is if people feel ready to go so soon after it. Back to details of vasectomy. It's also important to note that just because a man has a vasectomy, it doesn't mean that he cannot have ejaculate. So the seminal vesicle and the prostate and the bulbourethral glands, they would still be making the fluids. There just won't be sperm in the fluids after a few days. So there's still ejaculation, there's just no sperm in it. And then the last thing I wanted to tell you guys about this is that there is a faculty member at King that had a vasectomy in the morning and then came and taught their class in the afternoon. So that just shows you, number one, how dedicated our King faculty to teaching their students, and number two, how physically non-invasive that is. So on the flip side, the female surgical contraception is not so easy. Not so easy. And there are a couple different names for the female version. So you can call it tubal ligation is the most scientific word. So tubal, T-U-B-A-L, and then ligation, L-I-G-A-T-I-O-N. Or people will tend to also call it tubes tied. I had my tubes tied. And it's very similar in concept to a vasectomy, but the tube that's getting cut and sewn are the uterine tubes or the fallopian tubes. So one on each side. And because fallopian tubes are kind of deep in the female pelvic cavity, this is a more major surgery. So if a couple is talking about who should do what, the and surgical methods would be a good choice for them, it's way easier physiologically for male to get a vasectomy than female to get tubal ligation. One time in which it is somewhat easier to get a tubal ligation is when a woman is having a cesarean section birth, and she already has a pretty big-ish incision here, and that's a good time. If you're already having surgery, that's a somewhat easier way to get this done. I have a friend that would have chosen this, but was giving birth at a Catholic hospital, and they won't do that. So I had not thought about that. That is not okay with their church doctrine. So she did still want to have her child at that hospital because she had her other children there. So did not make that choice at that time. Think about what else I wanted to say about this. I think just write down it's a more invasive surgery. But for both of these methods, the failure rates are low. So we could put failure rates for both of these are very low. It is technically possible to reverse tubal ligation, but it's not It doesn't work that well. And also reversing these you would have to pay for that yourself. I don't think insurance would pay for it. You want to be sure. And I've also read recently there are some very young people who would like to do this, but doctors will not agree to do it because they think that they'll change their mind. And that's an interesting concept. Think about it. When should the doctor just do what you are wanting them to do, and what's the right thing to do, and how much should their professional judgment play into this versus what the person says that they want that time. Okay, so now we are going to talk about some pill-based methods of pregnancy prevention or pregnancy ending that are not included in your list of contraception. And this one versus the one coming up later, this one, these are both pills, but they do not act in the same way. So it's really important, I think, to know what these do and how they are not the same as each other. So the first one that we're going to mention, some people would call this Plan B, is one of the brand names. And this is known as emergency contraception. And if you're taking notes along with me, make yourself a note that right now this is available over the counter. So you can buy this at pharmacy, probably Walmart. This is something that people can buy over the counter. And if you would notice here, what is the drug? It's called levonorgestrel. And this is a progesterone drug. So this drug is based on progesterone hormone. And notice on here, it says not for regular birth control. Not for regular birth control. But what this is, it's the same type of drug that is in birth control pills. It's just a very high dose. So this is high dose progesterone in one pill. And the other things that the packaging says really clearly is that this should be taken as soon as possible within 72 hours after unprotected sex. The sooner you take it, the better this will work. So I put these numbers down here. If this is taken within 24 hours of unprotected sex, it has a 5% failure rate. So when they're saying it's 95% effective, it's 5% failure rate. But if you wait 72 hours, it has an 11% failure rate. And if you wait very much longer than that, it's not going to work very well. And the reason that the timing is so important is because of the way that this acts. So this is a progesterone drug, and it is designed to block ovulation. So make yourself a note, probably on this page, that what this does is it blocks ovulation and fertilization, but it does not block implantation. So the major evidence that exists for how this works indicates that it does well at blocking ovulation. It does well at blocking fertilization. It does not do well at blocking implantation. So if it does not block implantation, that tells you why the timing is so important. Because if you wait to take this until after implantation has happened, it won't really work. And there are plenty of women that have tried to take this too late and it didn't work because this is not blocking implantation. So what it does and what it does not do is important to understand for this pill. There is a pill that blocks implantation. That's a different type. And we'll talk about that in a minute. So some people would call this Plan B the morning after pill. That's what people tend to call it. And it is not the same as true abortion pills. That's the one we're going to mention how that works next. So true abortion pills terminate an implanted pregnancy, but these pills do not do that, and they're different from each other. So this drug, mifepristone or mifepristone, are the two different names of it. This type of pill will end an implanted pregnancy. This type is a true abortion pill. And right now, these cannot be gotten over the counter. This is the type you have to have a prescription required. And these days, it's a hot topic whether can people be prescribed these and sent through the mail to a state with abortion laws that start at a very early week. Like, I don't know how much of that news y'all read, but this is a big deal. And this is the type of pill getting sent through the mail, and that you have to have some type of prescription. Can that be through telehealth? Can that be through in-person visit? There's a lot of debate about these, but these are true abortion pills. These are doing something different. Either of these, if you wait too long, you've waited too long, but they're acting in very different ways. Neither should be used as someone's number one birth control method. That is not, in neither case is that a good idea. But knowing what they do and they don't do is important. This is a fairly new slide. Some of these pills can be done as a 1-dose pill or a 2-dose pill. And the drug in these pills, some states have proposed to let's just ban that overall. But there are other things that people use those drugs for, like inducing labor. It's the same thing. It's causing contractions. If you give it late in pregnancy, it will induce labor. If you give it early in pregnancy, it will expel an implanted embryo. It's also used for ulcers and other stomach problems, and is very important to have available for safe births later on, which is kind of ironic. Same basic type of drug. So when you, before we leave this section, when you go back and look at your table of methods, neither of those pills are on this table because they are not normal contraceptive methods. The morning after pill is just progesterone, basically in a big dose. The other one is a completely different drug that literally will cause abortion and will expel if you take it soon enough, and implanted pregnancy. So on the exam, there are certain things that I will ask you about contraceptive methods in a certain section on the exam. But the stuff about the 2 pills that we talked about last, those can be multiple choice or matching stuff, but I don't consider those normal contraceptive methods. If that makes sense. So what I want to do before we leave this section is to let you guys know on exam 5 how I test contraceptive stuff. So there's a section on the exam where I list a bunch of methods, and I try to line them up with how they're called in this chart. And the first thing to know about the methods is to tell me, is this barrier? Is this behavioral? Is this hormonal? Or is this surgical? I feel like there's 10 of these, or 10 methods, and then there's a blank and you fill in, is it behavioral? Is it surgical? And then for the methods that we talked about in these slides, I also will want you to know, are they low, medium, or high failure rate? And I think it's easier to just remember which ones are low and high, and then the rest are medium. And then the last thing that I will ask you about some methods is, what are the pros and cons, maybe? Like, what's a pro of each method, or what's something more negative about each method? And how does it generally work? Like, does that method prevent ovulation? Does it block sperm from ever meeting the egg? How does it generally work? And what are some pros and cons? So that section is probably about a fourth of the test, maybe. Something like that. Kind of a page on its own about contraception. And that will be the Wednesday after Thanksgiving that we have that. So we're next going to get started on our unit about pregnancy. And when I put together this unit, I was trying to think about, when I was pregnant, what were the things I did not know that are actually pretty common and pretty important in pregnancy that I didn't know until I became pregnant. So I've called this unit Lesser Known Pregnancy Facts. And the first thing that I want to talk about in relation to pregnancy is, what are the things that are actually dangerous during pregnancy? Because there's a lot of things that people say are dangerous during pregnancy. And some things are, and some things are, less good. But the reason I like to say this is because women that have a miscarriage will often blame themselves for that. Like, did I eat a hot dog that wasn't cooked enough? Should I have not been like doing my usual exercise? Did I cause this to happen? And that's usually no. There's really not that many things that will cause pregnancy loss. This is a list of some things that could actually. So there are some drugs that should not be taken during pregnancy, but there are some therapeutic drugs that do need to be taken during pregnancy. Hard drugs, illegal drugs, are not advised during pregnancy. Alcohol in large quantities is not good during pregnancy. Alcohol in small quantities is kind of okay in some cultures. Should not be having large quantities of alcohol. We want to avoid pregnant women having really high fevers for any reason. That can be damaging to a pregnancy. So healthcare for a mom to prevent them from having high fevers is good. There's a certain viral infection called cytomegalovirus that's particularly damaging to the fetus. Certain types of food poisoning, including one called listeria. So if you've ever heard that pregnant women should not eat sushi, lunch meat, uncooked produce, I'm trying to think of what are the other weird ones, hot dogs. Those are aimed at reducing listeria, unpasteurized milk, stuff like that. There is a certain bacterial food poisoning with listeria that can be damaging to the fetus. But don't be the lunch meat police. I mean, a lot of people get listeria from eating just a salad these days. So, one drug that's particularly bad during pregnancy is called Accutane. What is this for? You ever heard of it?
I'm not sure.
Yeah. Accutane is an anti-acne drug in pill form. So people with really bad acne might get prescribed Accutane. And if you're a male and you get prescribed Accutane, here you go. There's your Accutane. If you're female, you have to pretty much prove that you're not pregnant and sign a lot of release forms that you know the risks and so on. It causes birth defects. But the biggest one, the biggest thing that women can do to ensure a healthy pregnancy is just to get prenatal care. That's so important. And one of the reasons that the US has worse outcomes for moms and babies with maternal health is that we're not good at making sure everybody gets prenatal care. And some women who are on hard drugs or who are alcoholic or who are not maybe taking the best care of themselves might be afraid to get prenatal care because they're afraid if they go to a doctor, they will get turned in for being an addict or being under the influence. And so they avoid prenatal care, and they're the ones that need it the most. So I personally am opposed to any law that would prosecute a woman as a result of what was found during her prenatal care. But states are different about that. Like, oh, you're on drugs, we're going to put you in jail because you're endangering your fetus. Endangers fetus if you're afraid to get prenatal care. Okay, so what we're going to go through next are certain conditions or certain things that happen during pregnancy or might happen. And the first one, people tend to have heard of morning sickness, which is increased nausea, vomiting during pregnancy. And some people assume that this is supposed to happen during pregnancy, but it's very individual to the woman. So some women never have it. Some women have it for a while and then it goes away. It can be different with different pregnancies in the same woman. But if women have a very extreme version of morning sickness, that's a condition and it's called hyperemesis gravidarum. So hyper means too much. Emesis is vomiting. And gravidarum means pregnant. So hyperemesis gravidarum is excessive vomiting during pregnancy. And one famous person that had this was Princess Kate. And this would have been like when y'all were pretty young kids, and she was pregnant with her first child, who is like the heir to the British throne someday. So it's a huge deal. And in the UK, they love tabloids even more than the US. And so there are all these photographs of her when she was pregnant, and she's pregnant here, and people made so many comments about how skinny she was, how she wasn't gaining weight. And she had hyperemesis gravidarum with every child that she had, which were 3. And you're supposed to have 3 for the purposes of carrying on the, the line and the kingdom and whatever. So I would just, I'm sure she must have dreaded. It was tough for her. And we don't really know why this happens to some women and others not. But if women do have hyperemesis gravidarum, that needs to be treated because they will not be able to keep enough nutrition down to keep themselves and the fetus healthy. So one of the things that would be needed in this case are drugs that you take to make you stop vomiting. And there's one called, I think it's Zofran, Zofran, Zofran. Some people take that for motion sickness. It has works for that too. The next thing that does happen to every woman during pregnancy is a huge increase in their blood volume. So we're looking here at weeks of gestation, and this would start from day 0, week 0. What is the mom's normal blood volume, plasma volume, cell volume? So we're saying that the normal is starting here, and then along this axis, we're looking at how much more does it get week by week. So for example, plasma volume increases really dramatically by the time pregnancy is full term. So women will have about 1/3 more plasma than normal and more red blood cells as well. So there's about 30% increase in blood volume. And the point of this is to supply the placenta with extra blood and then also the fetus. So just that amount more of blood cells and blood plasma, that will contribute some to the mom's weight gain. So after delivery, within 6 weeks, it will go back to normal. It's not immediate. It's not immediate. So there's just a lot of fluid adjustments in the mom right after she gives birth. And when people tend to talk about that postpartum roller coaster, like it's physical. Like there's some just huge changes in her body to adjust to having less fluid and adjust to everything new in her life. But if you're going to have that much more blood in your body, you are also going to have more fluid retention generally, and more frequent urination. So more fluid, you get more filtration, you get more urination. And for the fluid retention part, if you're taking notes along, put underneath fluid retention, that the mom will have usually some level of edema or swelling. Some women would describe this as bloated. Some women, people say, oh, you look like you're glowing. It's extra blood supply. But not everybody feels like they're glowing. Some people just feel like they're bloated. So just greater blood flow all over the body, weight gain, fluid retention, more frequent urination. So because of this, the other thing I would like you to write down on this slide is this: monitoring blood pressure during pregnancy is critical. Thank you. Monitoring blood pressure during pregnancy is really critical. And when women go in for prenatal care, the big things that happen are take blood pressure, take their weight, you pee in a cup to see if your urine is healthy, and just kind of interview them about how they feel. And then later in pregnancy, also take measurements that relate to the fetus.
So, because women are urinating so much, is there an increased chance of, UTIs throughout the entire 9 months?
That's a really good question.
Since, they're having to,
I feel like it should be a decreased chance, but I don't know that for sure. Because the more often you urinate, the more often you flush bacteria out of the urethra. But I don't know that for sure. And the peeing in the cup is not for infection purposes, but for something else that I'm about to describe. Yeah. Prenatal care is not difficult or expensive in the long run. It's so important. It's such a good investment. So one thing that prenatal care appointments are set up to look for or test for is a condition called preeclampsia. Preeclampsia. And there will be a certain number of pregnant women that develop preeclampsia. We don't know yet why it happens. There's really not enough research into it. It's relatively common. So preeclampsia is dangerous for the mom and the fetus, and prenatal care is set up to check for it. And once it develops, we don't have a good way to treat it. We really cannot reverse it right now. So once it develops, you generally are going to assume that that fetus is going to be born prematurely. So this is how you know preeclampsia is happening. Three signs, or what's called the classic triad. And the first one is proteinuria. That's these together spell PRE, proteinuria. And proteinuria is having too much protein in the urine. If you have a lot of protein in your urine, you are losing protein more than you should. And it's also a sign of very high blood pressure. So second sign of preeclampsia is blood pressure that's not just sort of high, but really high. And women don't feel either of these things. They don't know they have protein in the urine. They don't feel high blood pressure usually. So this is part of the purpose of prenatal care, is to just check these basic things to see if this condition is developing. And the third sign is edema at a more serious level. So a lot of women will have swelling at some level, but edema has is a more extreme version of that. So you see here, they've done the ankle push your fingers in test to see if the dents stay. And then if they do, that's a sign of dangerous edema. This one, edema, it will also cause sudden weight gain because you've suddenly got more fluid. Extra fluid is normal, but a lot of extra fluid is abnormal. And that would be detected as extreme bleeding in a short amount of time. So when these things are happening in the mother, the preeclampsia, the danger of it is that the high pressure tends to damage the placenta. So the reason why preeclampsia is bad is because it runs the risk of damaging the placenta, and the placenta is the connection between the fetus and the mom.
So what exactly does it do to the placenta? Just make it thinner or shut off supply?
I don't know exactly, but something about having high pressure in the blood in the placenta will tend to make it malfunction. And that's about the best I can tell you. But if it malfunctions, the fetus loses everything. And so women that are developing preeclampsia, they will try to help them a little bit with, like, they're immediately going to go in the hospital and they get, I think, magnesium through IV. And I don't know what that does, but I think that's one of the things they will do right away, but it's not really going to reverse. They'll just try to stabilize it short term and hope that the fetus can develop past 23 weeks. But this is one of the major reasons why premature births tend to happen, is when women get this condition. And we don't know why they get this condition. It's a big danger. So as another thing that will happen at prenatal appointments is measurement of how well is the fetus growing. And Caitlin, you'll learn to do this probably on like some of those models downstairs, and then on real people. So there's a measurement of how high is the uterus, like high up. How high does it rise out of the pelvic region as pregnancy progresses? So if you remember in lab, did you all learn fundus? That's why we teach fundus, because it becomes important during pregnancy. So that top part, top curve of the uterus at 12 weeks, it's still down in the pelvis. At 16, it's still also pretty far down. But then after 22, it's supposed to be over the level of mom's belly button. And so if you got this picture, like once the fundus of the uterus rises above the belly button, this is when we would say the mom is showing, being big enough to push her organs around. So you can see it rises, and it's supposed to be certain number of centimeters correspond with certain weeks. And you can just measure that by putting a measuring tape on top of her pubic bone and stretch it and feel where the fundus is. And then that number of centimeters is supposed to track with the number of weeks. So if you've ever heard friends say like, oh, this baby's measuring big, means that the fundal height is a little bit higher than the number of weeks of pregnancy would suggest. And notice here, there's week 38. Oh, hey, I thought you were like somebody really late.
Yeah.
There's week 38.
2 minutes late. Yeah,
2 minutes till.
2 minutes still.
I haven't had people do that. And but then notice it went back down. You see that? 38 weeks. 40 weeks, it went back down. So if you've got this picture and you're taking notes, draw a little indicator. I found this so interesting. And that is what we refer to as the fetus has dropped. You ever heard that? You will. And what that is the fetus will be kind of settling lower down in the mom's pelvic cavity right before she gives birth. And when a fetus drops, he or she will be so far down that the mom will start to walk funny. And they tend to like kind of waddle because their pelvis is not working in the same anatomical way as it was. But there's also a little bit more room to breathe with that, slight extra drop down of the uterus as the fetus is getting ready to be born.
So do women have a harder time breathing when they're pregnant because of all the stuff?
Yes. And the shorter you are, hate to tell you, the shorter you are, the more drastic that is, because if people talk about being long-waisted versus short-waisted, pregnancy is harder for short-waisted women.
Don't you start to get a lot more heartburn when they start to drop because it's squishing really your?
Well, it's as they rise. So the
Right.
heartburn part is as they rise up because they're push up against the stomach and you can't eat as much at once. Yeah. And push everything up and acid might push up through your esophageal sphincter.
So as it grows, everything's gonna go up?
Up. Like up and back.
Yeah.
Yeah. Some people apparently love it. I found it okay. I mean, I didn't have a lot of problems, fortunately. Yeah. So we'll continue this the Monday after Thanksgiving. Stop recording. There we go.